Good afternoon and welcome to the Special Focus Dialogue, which is a collaboration between the Union for International Cancer Control, the Norwegian Cancer Society, and REACT. It's a real pleasure to have you all joining us, and thank you. Thank you for your time. I'm Shalini Jaishekhar-Zure, and I'm with UICC, and I will be your chair for the session. Today, we'll be talking about how cancer patients are the primary victims of the antimicrobial resistance, or AMR crisis, and the importance of coming together to address this issue. So antimicrobial resistance, or AMR, is a growing public health issue that needs urgent attention globally. And without working antimicrobials, including antibiotics and antifungals, routine surgery and life-saving treatments like chemotherapy can be life-threatening. And as many as 1 in 5 cancer patients undergoing treatment are hospitalized due to infections, and antibiotics are their main line of defense. In fact, infections are the second main reason for deaths in people living with cancer. So now we know that antimicrobials are a key and indispensable part of cancer treatment. But the emergence of drug-resistant pathogens are seriously affecting cancer care outcomes. And if we don't act now, all the progress made to date in cancer care will be undermined, seriously undermined. So in today's session, we hope to highlight the need for focus on stronger systems of surveillance, focus on sustainable access to and rational use of antimicrobials, and also strengthen collaboration towards a meaningful engagement of communities and civil society groups as key stakeholders in the global response to AMR. And our panel members will share critical work being done to address AMR in these areas I just mentioned. And we really hope to have a meaningful discussion on how we can address this problem, drawing from all our different experiences. Before I introduce our first speaker, I'd like to encourage our listeners to post your questions in the Q&A box anytime during the session, but we'll address them towards the end when we have the Q&A session. And I'd also like to please ask you to mute yourselves and only unmute yourselves when you're speaking. Thank you for that. So our first speaker is Dr. Lillian Sung, who is a professor and senior scientist at the Hospital for Sick Children in Toronto. She is certified in the specialties of pediatrics, infectious diseases, hematology, and clinical investigation. She has a clinical research program focused on improving supportive care for children with cancer. And her methodological focus is on randomized and observational trials, meta-analysis, and patient-reported outcomes. She is the principal investigator on multiple operating grants from the NIH, the Canadian Cancer Society Research Institute, and the Canadian Institutes of Health Research. And Lillian will talk in more detail on how AMR has a negative impact on cancer care outcomes. It's over to you, Lillian.
Good afternoon, everybody. I'd really like to start by thanking Shalini and the UICC for inviting my participation in this really important symposium and this really important working group trying to address AMR. So I've been asked to talk about the negative impacts of AMR on cancer care outcomes, and I'm going to talk about it from the lens of the pediatric oncologist. So next slide, please. Thank you. So pediatric cancer is an amazing area to be in right now because outcomes have continued to improve over time. And currently, we would expect to cure over 80% of children newly diagnosed with cancer. And that statistics is occurring throughout high-income countries. And that number is starting to rise even in the low and middle income country setting. And why has that happened? It's happened because we've had great progress in the way we treat our cancers, our ability to risk stratify patients, and very impressive innovations in immunotherapy, CAR T cells, blinatumomab, which are really changing children who used to be incurable to be long-term survivors. So next slide, please. In the backdrop of this amazing improvement in anti-cancer therapy, though, is the looming threat of infections, which continue to be a major problem in pediatric cancer patients, and for which we've had far less progress compared to our anti-cancer therapies. So infections continue to be a major problem because chemotherapy causes immunosuppression, including neutropenia. Our children require central lines, which provide a portal for infections. They experience mouth sores and GI toxicities. And when we think about what infections are the most important to children with cancer, they're really bacteria and invasive fungal infection. So bacteremia are bloodstream infections with bacteria. These are typically bacteria that live on normal hosts, but when you're immunocompromised or when you have a breach in the host defenses, such as mouth sores or GI toxicity, these bacteria from the mouth and skin can translocate to the bloodstream. And this is a very common and serious infection that typically can occur when patients have immunosuppression and neutropenia. And often the very, very first sign of bloodstream infections is fever. So we take fever during neutropenia very seriously in children with cancer. The other very important set of infections are invasive fungal infections, and the CT scan on the far right shows you an example of a kind of fungus called aspergillosis. These fungal infections are typically associated with not only neutropenia and intensive chemotherapy, but in children who are receiving prolonged broad-spectrum antibiotic therapy. And these invasive fungal infections are particularly difficult because we don't have great methods to diagnose them, and we don't have great methods to treat them when they become disseminated. So therefore, they are frequently associated with morbidity and mortality. So next slide, please. So what happens to a child, and when do they become susceptible to infections? So what happens with a child who's diagnosed with cancer is most of these children are treated with chemotherapy. So we treat them with chemotherapy in hospital, either in the outpatient or inpatient setting. We give them chemotherapy, and typically about a week later, their counts drop and their neutrophils drop to the point where it's dangerously low, such that they have neutropenia. While they're neutropenic, often the first sign of serious infection is fever, and therefore we teach our families that if your child has fever, this is a medical emergency and you must come to hospital right away. For some children, the risk of death is so high when they have fever, we don't even let them go home. We keep them in hospital the whole time they're neutropenic because we need to be able to treat them minutes after their fever starts so that they don't experience significant morbidity and mortality. When these children have fever, what we do is we do a clinical assessment, we take blood cultures, and really importantly, we must start antibiotics right away. We don't wait for those blood cultures to come back because the risk of bloodstream infections is so high that if we waited for those blood cultures to come back, we know that a reasonable number of those children would die while we were waiting for those blood cultures. And for those who do have a bloodstream infection or other invasive sites of infection, time is of the essence. So we must treat these infections as soon as possible. And we know that for every minute past an hour that we delay treatment, the risk of mortality increases. So it's really important that we not only treat them with antibiotics, but we treat them with antibiotics that are successful at treating the infecting pathogen. So next slide, please. So how does AMR affect what happens here, what happens to our choices and what happens to children? So when we're treating these children with empiric antibiotics, so that's the idea, they have fever and we're giving them antibiotics before we know what their cultures show. We must make sure that we treat pathogens that might kill the patient or that might be so severe that they might die. So we want to make sure that we cover those organisms, but we want to minimize unnecessary coverage because we know that the more antibiotics we give, the more toxicity there is, and the more we spur on antimicrobial resistance. The standard approach, according to clinical practice guidelines, in most settings for children with fever and neutropenia is to use one drug or monotherapy, and that works in most settings. However, if bacteria become resistant to common antibiotics, therefore, healthcare professionals cannot rely upon one drug and sometimes need to give 2 or even 3 drugs for all children who come in with fever and neutropenia. So what does that mean to the patient? It means that we risk toxicity, allergic reactions, it increased cost to the system. Some of these drugs cause kidney damage and hearing loss. And then importantly, the more antibiotics we give, the more antimicrobial resistance we have. So this becomes a vicious circle that once we have AMR, it encourages more AMR. So next slide, please. So what happens if I guess wrong? What happens if I use one antibiotic and it turns out that child is infected with a resistant antibiotic? Or indeed, what happens if AMR escalates to the point that I'm using 2 antibiotics, but that bloodstream infection is actually resistant to the 2 antibiotics I'm using? So blood cultures and susceptibility testing take time. They often take 24 to 48 hours. So that means that child may not be adequately treated for their invasive infection for up to 48 hours while they're infected. That is most certainly to lead to negative consequences. These children will develop sepsis. They often will need to go to the ICU, be put on breathing machines, so be intubated, have vasopressors to keep their blood pressure up, and this will lead to organ failure and death. So the consequences are dire for not treating their invasive infection adequately. Next slide, please. So are there data that describe an impact between AMR and poor cancer outcomes? And the answer is yes. The data are increasing that really solidly shows that if you have AMR, or if a patient has AMR, that is associated with the bloodstream infections that are persistent, that don't resolve, bloodstream or infections going to different areas, or metastatic bacterial infection. It's associated with children having to go to the intensive care unit, often for intubation and blood pressure support. And really critically, it's associated with death. So there's a direct correlation between AMR and mortality. So next slide, please. So 50 years ago, we couldn't cure many children with cancer. And when they would come to the hospital, we would essentially palliate them because we had no curative therapies. Today, in 2023, that is phenomenally rare. And many children with leukemia, we can say that we are very likely to cure you so that you'll grow up and you'll have a fairly normal life. I want you to envision a world that organisms now become pan-resistant to all antibiotics. And what might be happening here is that rather than the cancer being the major problem, it might turn out that infections might be the real problem. And can you imagine a world where children with a specific infection, we might have to say we have no therapies for that child? And I think that's the world we really must do everything to avoid. Thank you very much. My next slide is just my thank you slide. Thank you very much for allowing me to participate.
Thank you so much, Lillian, for that overview on just how important, critical actually, antimicrobials are for cancer care. Now, Lillian, I know you have to leave early, and thank you again for your time and participation. I hope you have time for one question. I'm happy to take one.
Absolutely.
One question from the floor, just one, unfortunately. Okay, well, I have one for you, Lillian. So, are there parts of the world that have a bigger problem with AMR in pediatric cancer care compared to other regions?
Thank you for this really, really important question, Shalini. So I'm sure during this symposium, people will be addressing the geographic heterogeneity in AMR. And it's really clear that there are parts in the world where AMR is a bigger problem, and that's probably multifactorial. It's going to be related to antibiotic stewardship. It's going to be related to agriculture and what's happening in terms of antibiotic usage. And it is clear that there are parts in the world that are much more dire. I think parts in the world where antibiotic prescriptions are freely given, particularly when prescriptions are not required, that AMR is really prominent. And I have colleagues that I work with that already have combination therapy for all children with fever and neutropenia. And I think one real question is if your AMR is already a problem, how do you dial back and how do you get back to a point where AMR is not a problem? And I think that's a real challenge. And I would also like to put out a challenge to countries where AMR is not a problem. I think it's a slippery slope, and I think it's easy to escalate antibiotic usage if we don't have AMR, because you say, well, I don't have a problem, I can use antibiotics. I think the challenge I would say is I think that there's no free lunch, and that I think for those parts of the world that don't have AMR, I think they really must strive to maintain that status.
Thank you, Lillian. Thank you for your time. So our next speaker is Dr. Diane Flayard, who is the Global Program Lead for Antimicrobial Resistance at BD. She works to champion and support the development of new antimicrobial resistance or AMR program initiatives in global awareness, infection prevention and control, and antimicrobial stewardship. Diane also leads efforts for the Antimicrobial Resistance Fighters Coalition, which was mobilized by BD. So we now know the negative impact of AMR on cancer care because of Lillian's presentation. But data is still scarce, and to address this AMR and cancer care, the AMR and Cancer Care Consortium conducted a multi-center study on the impact of AMR in cancer care, and Diane will talk us through this study. It's over to you, Diane.
Thanks, Shalini, and thanks for having me join this session today, and thanks to all the organizers for the event. So I'm going to share some data across a new study that's been recently published, and the manuscript is in development as well. Next slide. So the question that was asked and why the consortium came together was, as Shalini had pointed out in the opening, we know that cancer patients have a high risk of infection. We also know that they need antibiotics in order to resolve those infections, as Dr. Lillian just shared with us. However, the question that we had was, what is the actual burden of drug-resistant infections in the cancer population? And is that different than in the non-cancer population? We know there's been several op-eds and articles showing that today cancer patients are no longer dying from the cancer, but unfortunately it's these superbugs or drug-resistant organisms that are causing their demise. There was a publication a couple of years ago that actually called out specifically the lack of data in understanding infections in oncology patients. And it was a concern, because how do we know what that rate of resistance is in that vulnerable population? So with those questions being asked, a group came together to include UICC, the AMR Action Fund, BD, and many leading oncologists and infectious disease specialists in the US and Canada to brainstorm on how can we pull this data together, and how can we understand what the impact of drug-resistant infections are in the cancer community. So it's a three-phased process that we'll be looking to do. Currently, we're in phase 1, which is really just understanding the incidence of drug-resistant pathogens in the oncology patients. Next slide. So here you can see the preliminary data. So we had the opportunity to look at about 5 million patient admissions across a multi-year period. And of those 5 million admissions, over 300,000 of those admissions were cancer patients. About 6% of the admissions were cancer patients. And we defined a cancer patient by either being on a chemotherapy agent. There's a list of about 300 chemotherapy agents that were included, or if the patient was admitted onto a cancer ward within that hospital. So once we identified the cancer versus non-cancer populations, we then looked to see what were their rates of infection, and looking at the incidence of drug-resistant infections. So if you look on the graph on the right-hand side, you can see that we looked at gram-negative organisms and fluoroquinolone resistance. We looked at gram-negatives that were ESBL producers. We looked at carbapenem-resistant organisms, as well as multi-drug resistant gram-negative organisms. For the gram-positive infections, we looked at both vanc-resistant enterococci, as well as meth-resistant Staph aureus. And in the bar graphs, the different parts of the bar graph are representing the different sources. So we wanted to be broad in our analysis and looked at where these isolates were being recovered from. So whether those were blood, respiratory, urine, etc. And what we found is that the incidence of VRE and fungal pathogens was 2-fold higher in the cancer population. And AMR in the gram-negative pathogens was approximately 1.5-fold higher in the cancer patients. Overall, the cancer cohort has significantly higher incidence of AMR than the non-cancer cohort across all culture sources, except for a few there that are called out on the slide. So really, with this data was surprising to us. We knew that cancer patients had more infections. However, one would think that the proportion of drug-resistant infections between the cancer and non-cancer patient would be somewhat more similar than what we see in this data set, which is dramatically different. And what is unique about this data is that there have been publications that have looked at a hospital-level impact of patients who had cancer and drug-resistant infections, but there had not been a study this broad nor big to really understand that complexity. This included about 250 or so hospital systems that were analyzed. Next slide. And looking specifically at sepsis, this is the data pulled out for just isolates that were recovered from blood cultures. And you can see here that there was a 2-fold increase in incidence of resistant pathogens. And based on what Dr. Lillian had talked about, the impact of sepsis in this vulnerable population and how quickly these patients have to be managed, knowing that the increases of resistant are so dramatically higher in blood cultures and those organisms causing sepsis, it really makes us question, is monotherapy, do we need to do dual therapy? Many of the questions that this data brings forward. And you can see there's about 20,000 isolates in this analysis. So once again, a very broad data set. And I should note that these are all 30-day non-duplicative isolates. So a patient may get tested more often, an oncology patient. However, these are all non-duplicative isolates showing individual infections. Next slide. And to conclude, I think I highlighted the impact that we're seeing, almost a 1.5 to 2-fold increase in AMR and key pathogens versus non-cancer patients. These findings really do highlight the need to enhance antibiotic stewardship, diagnostic stewardship efforts in hospitalized cancer patients. The need for patient-specific antibiograms to understand what organisms patients are colonized with that potentially cause infection may be very important. And you can see in the bottom of the slide some nice graphics that have been developed by the Cancer and AMR Consortium. And I think the quote from Dr. Mallon that this is not a future threat, but is an issue that's here and today, is I think that this data clearly shows that in this most vulnerable population, we really need to be conscious about the impact of AMR in the cancer community. With that, back over to you, Shalini. Thank you.
Thank you so much, Diane. So we have data, and that too from such a large data set, to back up what we already know. And thank you again for walking us through this multi-center study. And hopefully we have this data and the numbers to take it to policymakers and use it for advocacy. So thank you, Diane. Our third speaker is Professor Scott Howard, who is a pediatric oncologist, epidemiologist, and information scientist who specializes in oncology supportive care and program development in low and middle income countries. His research uses integrated information systems and networks of experts to streamline healthcare and research. He founded Resonance to amplify health everywhere through research, education, and technology, and has also established the Global Neuroblastoma Network and Acute Leukemia Research and Care Network, where AMR is actually frequently discussed. And Scott is going to talk to us about the importance of data and surveillance systems to address AMR and also ensure optimal treatment. It's over to you, Scott.
Thank you so much, and thank you all for being here. I really appreciate it. I will now take you from Diane's data, which is my favorite kind of data, clean medical record data that just comes straight from one electronic system to another, no human touches it, to what is really common in probably 80% of the world. Yannick, if you could show the next slide. You see this paper on the left. This is a typical blood culture report from an unspecified country in Latin America. And you see basically there's a check mark by what we're going to do. This is a check mark by a human pen on this piece of paper. There's a yellow highlight to remind the doctor what bacteria it is. But the happy thing of this piece of paper is you see the category in the CAT1, it's all sensitive, 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 sensitive. So this E. coli that grew from this child's blood can be treated with almost any antibiotic, and many of those antibiotics on the list are available in the country where this patient was treated. Next, please. So the trouble, though, is how do you take a system where you've got these piles of paper in the lab and piles of paper on the ward and piles of paper in the patient's chart, and then develop this into something that can be used day by day by the clinicians so they can take a good decision? So I was really happy when UICC, in fact, the people here on this call, Shalini being one of the principal leaders, developed this AMR control supplement, which was specifically about how to control antimicrobial resistance in cancer patients. Next slide, please. So our part of that was actually to talk about information systems to integrate every data collection effort into a single system of information that could be used for multiple things. So in many cases, there's a cancer registry that has some personnel that are typing in data about the cancer patients. They might type in this patient has an infection. They might type in some details about the infection, a bacteremia with an E. coli. Rarely would they type in the real details about the sensitivity of that bacteria. Meanwhile, somebody else is over in the microbiology lab trying to create the antimicrobiogram for that hospital. And it really leads to a lot of extra work that is sort of could be eliminated if both groups would be working together. And actually, there are usually 5 or 10 of these groups working in parallel, creating data sets that don't help each other out. And so the goal here was to identify early changes in AMR rates, to use the antimicrobiogram to improve care, to have real-time updates to the antimicrobiogram, not requiring an annual review process and annual manual data entry. And then finally, to provide a context-specific antimicrobiogram. For example, a patient with cancer versus a patient without cancer. They actually have different microorganisms that cause their infections. So if you just take the hospital antimicrobiogram in a typical children's hospital or adult hospital, it'll have certain resistance patterns. But if you say, well, what about in the cancer patients? It's actually almost a completely different antimicrobiogram, which means you potentially could be using the generic one that applies to the ER and that applies to the neurology patients and other patients, but that may be really woefully inaccurate with the cancer patients. So let's go to the next slide. So information, all this information, here's an antibiogram where you see the red is the resistance and the green is generally sensitive. It's a lot of data. To create this one single slide, it's so much work. Each square, each little red or green or white or yellow square represents dozens or even hundreds of cultures, blood cultures, urine cultures, and bacteria whose sensitivities had to be measured. And not only that, typed from that piece of paper into some database and then integrated, cleaned up, and synthesized to create this antibiogram. So in the next slide, we're going to see how we make this much simpler. And the way we make it simpler is we use the free Resonance Patient Center, which is a hospital registry, a clinical trials management system, a scheduling system, a palliative care system. So it's essentially a cancer-specific software that's provided by my organization, Resonance. It's available free of charge for all sites in low and middle-income countries. Then what we do is in the microbiology module, actually send the data to an R package. And there's an R package, the R statistical language, actually has a whole section about antimicrobial resistance and antibiograms. So we didn't have to create that ourselves. We just send the data there. Then the output is what you see, the red and the green squares, which are directly from that hospital. But what it means is every single time a patient in that hospital has a bacteria grow, if they type in the sensitivity pattern of that bacteria, you can update the antibiogram every minute if you want to, instantly, with every single new culture that comes back positive. So ever since we developed this, I've been asking around, how often do you, hey, dear friend in Honduras or Myanmar, how often do you update your antibiogram? And very often they say, oh yeah, we have a very strict hospital policy. It has to be every 2 years. And I say, oh, okay, well, how often, when did you last do it? They say, oh, well, and then they name a date that's 7 years in the past. And so, but any day now we're going to do it. So the goal here is to not do things by mandate where you have to do it, even if it means deferring some other important work, but instead to do it by habit, where every culture that's positive, you just do it. Because what you really want is in the lower left-hand corner, you see the guidance to the clinician. And the guidance to the clinician, again, it's a real-time guidance. This patient just grew an E. coli. We don't know its sensitivities yet. What should we do with the antibiotics for this patient who's on the oncology ward? So they're different than a patient on the neurology ward. So we want to limit to the oncology cultures and the antibiogram for oncology patients. Next one, please. And here is the fundamental idea. People are busy everywhere. People are especially busy in low and middle income countries where the information systems are often paper and terrible. And so the worst thing is to make people put in data in 5 different places. So here's just a colorful example. In purple, let's say you're running a clinical trial for a patient and a patient is enrolled on the clinical trial. You're going to put in all the purple things. If you're doing a cancer registry, you're going to put in the orange things. If you're doing an AMR database, you're going to put in the green things. If you do this all in a single system, which is provided at no cost to the hospitals and integrated with open source free software like the R package for AMR, then suddenly maybe the green team can put in just 2 green boxes and the orange team, the 2 orange ones, and the purple team, the 1 purple one. And next thing you know, all 3 groups of stakeholders have access to all the information they need to make the best analysis and support the patient care. Next slide and final slide. So the worst antimicrobial resistance, in my opinion, is the resistance that comes because you don't have the antibiotic that you need. In the next slide, we're going to see a baby who had a bacteremia with Acinetobacter baumannii in the blood. And I want to thank his mother for agreeing to share their picture and their story. This is a patient from Honduras. And you see there, this Acinetobacter, notice at the bottom, interpretation, R, sensitive only to tigecycline. And turns out tigecycline was not available in the public hospital where this child was being treated. So is this a resistant organism? Well, it's resistant to a lot of things, but it's sensitive to one very important, useful, available antibiotic that just happened to not be available to this specific child. So then you have to ask yourself, what if we had an infinite supply of antibiotics for people in high-income countries, but they didn't reach people in low and middle-income countries? Then we could have this problem of AMR could persist far longer than it needs to persist. So for me, it's 2 things. It's one is creating the right governance structure to reduce antimicrobial resistance. The second is inventing new drugs to tackle antimicrobial resistance. But the critical 2B is getting those drugs to everybody who needs them. And so once again, I really thank you, Shalini, for organizing this. I think this is such an important topic. And I want to invite you all to our Drug Access and Quality Network. At first, it was just a drug quality network dealing with falsified or biosimilar drugs of low quality, like asparaginase is one of the most commonly used low quality drugs. And then we realized access is equally important because you could have a very high quality drug that is in somebody else's country. It doesn't do you any good. So I invite you all to join this. I'll put my email in the chat.
Thank you so much, Scott. Thank you for the presentation, and thank you for highlighting how important it is to merge cancer registry data and microbiology data, basically getting the groups together to ensure appropriate treatment and also address AMR, and of course, also make sure that these treatments are available when they're needed. So thank you so much. Our next speaker is Dr. Alexandra Cameron, who leads a team in the World Health Organization's AMR division focused on fostering the development of new, high-priority antibacterial agents and ensuring equitable access to both new and existing treatments. Previously, before joining WHO, she spent 11 years as a senior technical manager at Unitaid. And in this role, Alexandra led the development and implementation of strategies to support R&D, innovation and early product access across a range of portfolios, including malaria, childhood fever management, reproductive and maternal health, and of course, AMR. So Alex will talk about the importance of ensuring equitable and appropriate access to treatments. It's over to you, Alex.
Thank you so much, Shalini, and thanks so much to the organizers for being invited to participate in this fascinating discussion and to be on a panel with such distinguished panelists. I've really enjoyed all the presentations so far. As Shalini mentioned, I'm going to talk about access to both new and existing antibiotics and some of the initiatives that we're taking to try to address access issues, especially in low and middle income countries. And then finally, I wanted to conclude with a few words about the UN high-level meeting on AMR that's coming up in September 2024 and where this topic may factor in. So over to the next slide, please. So before we get into access, my first slide is actually on the research and development pipeline for new antibacterials. And it's probably already well known in this audience that the R&D pipeline is relatively dry and certainly insufficient for what we need to tackle the increasing emergence and spread of AMR. In the past 5 years, we've had 12 products approved, but 10 belong to existing antibiotic classes. Of the 2 that we consider innovative and the WHO innovation criteria are around new chemical class, new target, new mode of action, or lack of observed cross-resistance. So based on those criteria, 10 of the 12 did not meet those, and we had 2 that did. And only 1 of those 2 addressed what a critical bacterial pathogen as per the WHO priority pathogens list. So that just gives you an idea of the challenges that we're facing. And the clinical pipeline tells a similar story. We have 27 products in the clinical pipeline, but again, only 6 are considered innovative. And again, only 2 of those 6 address 1 or more of the critical gram-negative pathogens. So we have a serious issue with R&D, and I think that is fairly well known, but we also know that even when we do have new products that reach the market, the story doesn't end there. There's a whole pathway that's needed to ensure that those actually make it to the patients that need them, and that we have our objective is to reach patients and have access, and particularly equitable access. So if you move on to my next slide. So we have access challenges across the spectrum of both new products, but also for existing antibiotics. With new products, we know that there are issues in terms of lack of a viable market. These are largely reserve antibiotics that are intended as last resort products. And then by definition, their market size is small, and there is a limited incentive for suppliers to make them available and to pursue registration in a large number of countries. So this is a sobering statistic. Of the 25 products that were approved between 1999 and 2014, only 12, so less than half, were registered in more than 10 countries. So with these products, becoming available and all of the efforts, the significant effort and cost to actually develop them, once they're actually available on the global market, they're actually not registered in many, many countries, and particularly in low and middle income countries. And the root causes of this are numerous. There is, of course, a very small market country by country for these products due to their last resort reserve status. Often they're highly priced and sometimes priced out of reach for certain countries and certain drug budgets. And suppliers also cite, concerns over appropriate stewardship and the ability to control the use of those products in certain settings as a concern that they have sometimes in deciding where to register the products as well. For existing antibiotics, we have numerous challenges along the value chain that can limit their access to the patients who need them. Starting with inability to forecast accurately and understand what the true needs are and true demand should be. In low and middle income countries, we also have problems of limited drug budgets. When products are available, particularly narrow spectrum antibiotics, we often lack the diagnostics to accompany them and the diagnostics capacity to actually determine when they should be used and whether they should be used. And of course, at the end of the chain, at the level of the patient, we also have misdirected use of products sometimes to the wrong patient. So even if we have the products we need, once they're inappropriately used, they're then not available for the patients who need them. So it's a very complex array of challenges to address. One of the challenges that I want to focus on is the problem of shortages, which have many causes, including supply chain interruptions. But shortages are really a pervasive issue, both in high-income countries as well as low and middle-income countries. And our particular problem for antibiotics compared to other drug classes. So here, just to give you a flavor, 63% of hospital pharmacists cite antibiotics as the products most frequently in shortage. And the consequences of these shortages can be quite severe. So if you move on to my next slide, please. So actually, I want to come back to the issue of high price for a minute and just show you some data on reserve antibiotics that are recently approved. So we have Ceftaz-Avi in the top row, and this is showing price per vial across a number of countries. And what I wanted to highlight here, and you can see the pricing country by country, and across the board, it's high, but it's also very variable. So you also see that the prices can vary, from approximately $40 a vial in India to over $800 in Egypt. So we have a serious issue, not only of high prices, but also of variability from one country to the next. Next slide, please. And then coming back to shortages, here is just another piece of data that shows you from the US Pharmacopoeia that shows you different classes of medicine products and the proportion of drug shortages. And here you can see that antibacterials, 20% were in shortages in this data. And so that's already a really high number. But what's a bit striking as well is when you compare that to antifungals, antiparasitics, or antivirals, it's disproportionate. So we have issues with antibacterials that we don't have with other product classes. And so why is that? What are the reasons that antibiotics are so difficult to keep in stock? And I think I mentioned a few of the root causes before, but of course, we also need to take into account surges in demand that can occur due to outbreaks, and that's a particular challenge with antibacterials. But also from the market side, a lot of the products that we're talking about are quite old by now, with many generic competitors, and very, very thin margins. And what we see is a lot of exits of market authorization holders who just don't have a profit margin to be gained anymore from supplying these products. So as suppliers exit the market, the overall supply goes down and we end up in a shortage situation. And there's been a lot of coverage of these issues, in particular for benzyl penicillin over the past years. And I'm sure that you've also seen coverage of amoxicillin shortages as well, including in Europe and including up until last winter. So these are very real issues also for high-income countries and LMICs alike. Next slide, please. And in terms of the consequences, this is a survey from Europe of hospital pharmacists looking at some of the consequences, which are really quite concerning. So substitution with equivalent drugs, which is what you would hope to see, is at the top of the list of impacts. But substitution with inferior drugs happens sometimes or always. 50% of pharmacists said either sometimes or always. Rationing of drugs, just under 50% of pharmacists said that happened sometimes or always. Medication errors are also very high. If you look at the bottom on financial consequences, more expensive alternatives, again, happen always or sometimes. 50% of hospital pharmacists cite that. So we're talking about very negative clinical, but also economic impacts of these shortages. Next slide, please. So what is WHO doing about this? How is WHO aiming to tackle some of these issues, and with antibiotics in particular? And here I wanted to mention a new initiative that we're working on in partnership with GARD-P, which is the Secure Initiative. And this is a partnership initiative that really is aimed at improving access to new, but also to existing antibiotics in a sustainable, equitable, and appropriate way. And how we're going to do that, I think I'm probably running out of time. So maybe I'll stop there on the overall aim, but I'll move on to the next slide, which describes in more detail what Secure aims to do through our toolbox of interventions. So the first thing we did was to look at these access challenges across our different, what we call antibiotic archetypes. So starting with the access antibiotics, which are typically the high volume, off-patent, very competitive market, very affordable, usually products. And these are products where we usually see problems of shortages. And all the way across to our reserve antibiotics, which are the ones I was talking about earlier that are typically single supplier, relatively recently available, and of course, low volume by definition, where we see mainly issues of affordability, no controlled introduction mechanism, and a lack of registration overall. And some of the tools that we think Secure can help with in improving access really focus on improving the demand predictability and the attractiveness of suppliers to really get in and supply these products in LMICs. So some of the things that we're working on there is improving the forecasting of these products through a forecasting model that's going to be under development in the next couple of weeks. So we're starting that in the next couple of weeks and will be available in 2024. We're also exploring the potential of including selective antibiotics in existing pooled procurement mechanisms to aggregate demand across a range of countries and use that to improve the attractiveness for suppliers and also bring the prices down through greater volumes. A pooled procurement mechanism also gives you a good opportunity to have a strategic stockpile of certain products that are amenable to that intervention and to be able to provide those in a very rapid time frame to countries that need them. And the other thing that we're also exploring are the complementary economic tools that would come in alongside procurement tools to be able to support access. So here we're looking at either catalytic subsidies to countries, especially for the very high cost reserve products that could initially bring the price down and allow countries to start buying these products in the very low volumes that they're needed and make them available and start gaining evidence on how to use them in the right patients and appropriately, as well as potentially a revenue guarantee type mechanism that would allow for a delinkage of volumes from sales, which is a good stewardship practice, but can also increase the predictability of revenue to the suppliers as well in this very small and unstable market. All of that is supported by better market intelligence, which is something that we're already actively working on. And of course, none of it works unless you have the regional and country activities that support, last mile access to patients. And here there's a range of activities that are needed, from simplifying antibiotic portfolios in countries to be more evidence-based and also efficient, working on new product introduction strategies, stewardship, and of course, all supported by evidence generation. So this is the secure model. It's still under development in 2023 and most of 2024, but the next steps really are aiming to start putting some of these tools in our toolbox into a proof of concept towards the end of next year. Next slide, please. So moving on to the UN high-level meeting, I wanted to say a few words about this at the end of my presentation, because this is, of course, a unique opportunity to secure political commitments for AMR, including on R&D and equitable access, not only to antibacterials, but also to other important commodities that we need for AMR, such as diagnostics and vaccines. And so this is just showing the pathway from 2016 to today, from the first UN high-level meeting on AMR and the political declaration that came from there in 2016, and what's happened with public-private partnerships for AMR R&D along the way. And what you can really see here is that the 2016 UN high-level meeting was really a landmark moment for AMR overall, and many really important things happened since that high-level meeting. But just looking at R&D and that landscape, you can see that after 2016, we had the establishment of multiple initiatives to support R&D for AMR, such as CARB-X, GARD-P, also the AMR Action Fund in 2020, the establishment of the AMR Industry Alliance in 2017, the AMR R&D Hub was established in 2018, and later on in the latter years here towards 2021 and 22, we start to see many commitments towards also pull incentives to pull and provide that financial incentive for products that actually make it through the R&D pipeline to assure them a viable market on the backside. And here we have initiatives such as the UK subscription model, the Swedish revenue guarantee, and others coming in as well, Canada, Japan, and several other G7 countries. So we've really seen a big momentum since 2016. So where do we go from here and in the lead up to the 2024 high-level meeting? So for the 2024 high-level meeting, of course, this is a member state-driven process, and we've just had the two co-facilitators of the high-level meeting appointed in October. Those are the ambassadors of Barbados and Malta, and they will facilitate the member state process towards the meeting itself and the political declaration that ensues from that meeting. However, that's supported by both the quadripartite agencies on AMR. These are the 4 UN agencies that form the quadripartite, as well as the Global Leaders Group on AMR. And here I've just shown some of the early enrolling suggestions that the Global Leaders Group on AMR have for the lead up to the high-level meeting. And financing is clearly one area. And within financing, you'll see that investments for R&D and equitable access are among the top topics that need to be addressed. On to the next, and I believe my final slide. So here's a photo from the last GLG meeting in February, which was in Barbados. And here I wanted to mention a little bit more about what the GLG is doing to address what they have considered and called the antibiotic pipeline and access crisis. They have deemed that title, and they have underscored the need for innovative and disruptive measures. And so since February, what has been happening is that we as WHO have been supporting the GLG to develop their messages and their recommendations on how to address the pipeline and access crisis. And so that is being developed in the form of a position statement that should be launched early in 2024, and with plenty of time for political advocacy in the lead up to the high-level meeting. So that's clearly one of the avenues. There's, of course, many other stakeholder engagement opportunities, and I can talk about those more if we're interested in the discussion times. I think I don't have time now, but there are many ways to engage with the high-level meeting as partners, and to raise some of these issues and ensure that we have strong and actionable commitments out of the HLM, and also accountability mechanisms. So I think that's my last slide, and I'll stop there. But thanks again for the opportunity, and very much looking forward to the discussion.
Thank you. Thank you, Alex, for pointing out how important it is to push for novel medicines, but also for stressing the need to ensure optimal use of existing therapies, and also for introducing the discussion on HLM, which hopefully we'll have later during the Q&A session, the high-level meeting, because our next two speakers will go into more detail on this. So our next speaker is John. John Kirkness is the head of international affairs at the Norwegian Cancer Society. And previously, he headed the Department of Cancer Research, Prevention, and Cancer Care. And he has also been a board member of the Gemini Center for Sepsis Research. And he has wide experience in political advocacy, organizational development, and leadership. And John is also a member of the UICC's Task Force on Antimicrobial Resistance and Cancer Care. And he's also a member of the Norwegian Directorate of Health Users Council, who promote the user perspective in strategically important matters and processes in the directorate, within the directorate itself. And John is going to talk about how we all need to come together and work towards a global response and ensure political commitments. And as Alex mentioned, ensure that member states reaffirm commitments made in 2016. John, it's over to you.
Thank you, Shalini, and thank you everyone for joining. From previous speakers, we have been reminded about the profound impact on AMR, on cancer patients and whole healthcare ecosystem. As Shalini said, in this presentation, I will discuss the role of global governance and the need for regulatory framework to combat this pressing global challenge. And also, how can we mobilize civil society in bringing this topic to the highest political agenda, as Alex was talking about, and make sure that the next year's meeting at the UN will result in a strong commitment, measurable actions, and adequate funding. Next slide, please. First of all, some sentences about Norwegian Cancer Society. We are one of the largest organizations in Norway, representing the voices of those affected by cancer. We work to prevent and to improve quality of life for patients and their family. Next slide, please. Why is AMR important for the Norwegian Cancer Society? Next slide. That's patients and families. By using the voice of our patients and the threat of cancer care being set back by AMR, we have been able to raise awareness among the other cancer organizations and gather support for government-led initiatives to curb AMR. Next slide, please. Here you can see in 2017, we started an international campaign, the first of its kind, by a patient organization. We strongly believe that Cancer Society can make a difference by representing the patient's voice and have the capacity to impact policy. Here you can see our former CEO, Annelise Ryhr, and our health minister in Norway for some years ago, Bent Høie, who launched the campaign. Next slide, please. Here you can see some of the impact already in 2017. We got good responses, but we had to keep on the good work. So next slide, please. We also made our own exhibition, Hanging by a Thread. It was shown in Oslo, in Stockholm, in Copenhagen, and in Brussels before the pandemic stops further travels to Moscow, Geneva, and New York. And we have also a formal partnership with the WHO Regional Office for Europe, where our society is supporting the work on AMR using the impact of cancer patients as cause to adverse effect of AMR on global health. Next slide, please. For the last 2 years, we have been working in a campaign coalition with the aim of mobilizing civil society globally to urge their governments to initiate negotiations for a global treaty on AMR. With the support of almost 20 different civil society organizations in Norway from various sectors such as health, environment, development, animal health, and agriculture, we started a national coalition with a wish to expand to an international effort. These successful national measures Norway has taken, including reducing antibiotic use in the health and food sector, will be in vain if we do not gain control of AMR globally. This problem of mis- and overuse of antibiotics must be solved at an international level. Next slide, please. Political work has been done on the topic for several years, including in the WHO, as Alex just mentioned, and in the UN. But this has not been so sufficient to limit the emergence of antibiotic use on AMR. The ongoing negotiations regarding the new pandemic treaty don't look promising either. We think a new antibiotic convention with an equity lens, a binding international framework that provides stronger incentives for the sustainable use of antibiotics is needed. Achievable and likely the most effective long-term solution to AMR. Next slide, please. Alex just mentioned the Global Leaders Group. They work strongly for the inclusion of AMR within a One Health perspective to be part of the new pandemic treaty. We wish to think that the timing of political work on an international framework is good now, that there is a strong political focus on global infectious diseases and the importance of prevention and preparedness. But reports from the ongoing negotiation talks about stumbling blocks and the text being watered down for each meeting. We think that Norway is in ideal position to take a leading role in such work, with a broad support from the antibiotic issue across sectors nationally. But no government can effectively address the problem alone. All countries are both contributing to and as affected by antibiotic resistance, and there is a need for a global governance mechanism, a mechanism that effectively incentivizes states to curb misuse, overuse, and ensure of more equitable distribution of antibiotics globally. Next slide, please. Here you can see the campaign coalition and the organization in the coalition. Next slide, please. We work together with the collaborating organizations in the campaign coalition are approaching Norwegian politicians, trying to evaluate their interest and willingness to promote this work and to take a lead internationally. There is a broad political agreement on the need of stronger measures, and we have applied funding for the Norwegian Development Fund, NORAD, and we will have a meeting with them next year. Until now, our effort has been on voluntary basis, and there are needs for more funding. Next slide, please. We strongly think we need to collaborate on innovation, new funding mechanism, and better and more equitable access to all. We strongly think there is a need for an overarching legal framework, and civil society has to take an important role in bringing this forward. Next slide, please. As you can see, thank you for listening, and let us all mobilize to get a stronger commitment out of the next year's high-level meeting. Thank you.
Thank you so much, John. Thank you for highlighting how important it is for us to all come together and push for action, especially with the high-level meeting coming up next year in September. Action with funding, as you mentioned. And we also heard how AMR is disproportionately affected by the cancer community. So there's really a need for civil society, our community, to come together and come up with really clear asks to raise key issues and shape the agenda and really push for commitments. So thank you for your presentation. Now I'm going to hand over our last speaker. Hi, Andrea. It's Andrea Caputo. It's Dr. Andrea Caputo, who's a molecular microbiologist and global health advisor at REACT Europe. His work focuses on several European Union and international policy dialogues on antibiotic resistance, including One Health R&D and cancer treatment outcomes. Prior to working at REACT, Andrea worked as a program officer at the Stockholm International Water Institute and he has also been an expert consultant with the FAO, the Food and Agricultural Organization at the UN. So Andrea will also address access to treatments, especially in LMICs, reinforcing some of the messages we have just heard. He will also talk about coming together for the high-level meeting on AMR next year as an opportunity to get governments and stakeholders together to commit to action and the importance of community engagement. So Andrea, it's over to you.
Thank you so much, Shalini, for the invitation, for being here. And I have the honor of being the last one in the panel. So probably you might hear some messages that you already have heard. But yeah, we can move on to the next slide. And I hope to provide a unique perspective from REACT side. Before deep diving into what are my messages for today, I just wanted to remind, for those of you perhaps that don't know much about REACT, what REACT is and what values and vision we have. For us, from the beginning, since 2005, sustainable access to effective antibiotic has been one of the main pillars. Together with antibiotic effectiveness and considering antibiotics as a public health good. Also very important for us, as you know, REACT has nodes in different continents, in Asia Pacific, Africa, Latin America, where I'm sitting right now, in Ecuador, Cuenca, and in North America as well. So also context-specific solutions are extremely important. Not least building an ecosystem to antibiotic resistance, where we understand the essential roles also from a One Health perspective, so including humans, animals, and the environment as well. Last but not least, I want to remind everyone that we are independent from the pharmaceutical industry and that we don't accept funding from them. Next slide, please. So I'll start my points here, my talk, talking about ensuring access to effective antibiotics, which you've heard before, and especially in low-middle income countries. Next slide, please. You've probably seen this slide before. I think everyone in REACT presents this at every meeting, but I still think it's important, it's relevant. It's a very simple image, but it does convey the message, I believe. Here we see that antibiotics are at the base of this pyramid, where you see what is the medical practice today. And if you can click one more, please, you see that when antibiotics are coming, they're not working anymore, the entire pyramid falls down. And we see at the top of the pyramid, there was cancer treatment. So that's also an issue, of course, for cancer. But then when antibiotics don't work anymore, from simple infections, we can also have a lot of death. Next slide, please. Here you saw before also from Alex from WHO how the pipeline looks like. I just want to perhaps provide some more numbers that only 35% of antibiotics in clinical development target priority pathogens. And of these 35%, nearly 65% is in phase 1, which is the first phase of the clinical development, and only 6 fulfill at least one of the 4 criteria in innovation. Next slide, please. And here I'm hoping to provide what is React perspective on the issue and perhaps also the solution on it. As you've seen perhaps in my title and subtitle, we published a couple of years ago a report which was called End-to-End Report, Access to Everyone, Everywhere. And there was listed 5 different challenges and also 5 different potential solutions to it. And for us, it's extremely important indeed to take an end-to-end approach to antibiotic research and development to achieve sustainable access for everyone, from discovery to patient access, considering the entire chain of actors, investments, regulatory measures involved in bringing new antibiotics against the most resistant bacteria in a sustainable and affordable way. You can do perhaps one more click, please. I also want to mention that last year we launched an initiative called REMAP that stands for Revisiting Effective Models to Advance the Antibiotic Pipeline, which aim to find ways on how to best reinvigorate the antibiotic pipeline with the public health interest in focus. And for this meeting, which I set up last November, we invited 15 senior leading experts, academics, and members of civil societies representing 9 different countries from the field of antibiotic R&D. There is a report, which this one that you see in the slide is a link. I'm happy also to eventually share it, where you can also find perhaps some solution to the challenges that have been proposed today. I also heard before that the linking part was mentioned. So for us, it's very important, the link in the R&D costs from sales and revenues, not least ensuring production, quality, procurement, and access. And one important outcome of the report here is that we don't need to think about access just at the very end. So the importance of the end-to-end approach is that we think about all the different steps from the very beginning, because everything is interconnected. So whenever we are also coming up with a new molecule, we really need to think about how can we make sure that access is guaranteed to everyone everywhere. Next slide, please. And here you heard before from my colleagues, both from John and Alex, talking about the UN General Assembly next year, 2024, and the great opportunity that is to set targets and concrete commitments. Next slide, please. You already seen also this slide or a version of it, which we also borrowed from WHO. And this is also to show where we're coming from the 2016 UN General Assembly and all the path to, until 2024 next year. I won't spend much time here. Next slide, please. What I wanted to mention instead is that last May there has been a dialogue meeting in Uppsala organized by REACT, where we had several experts, including WHO, discussing several issues, including also the road forward towards the high-level meeting next year. And all the participants came up with different highlights and targets and type of commitments that are needed. I won't mention all of them because of time, so if you can do one more click, please. I just want to focus here because of my next chapter in this talk in investing in civil society mobilization and meaningful engagement from local, people-centric community level to the global level, ensuring their fair representations in governance structures and decision-making process. I also want to mention that last week we launched this report that you saw the image in my previous slide. There's been a webinar and it's been recorded, so you will also find it on the REACT website. Next slide, please. And this was the perfect segue to my last chapter here about community engagement and civil society mobilization, which are critical elements for a robust health response. Next slide, please. We saw in the slide before and the roadmap how everything started also from 2016 and when the ICG also was created. And one of the call for action for the ICG was indeed referring to the need for a systematic and meaningful engagement of civil society groups and organizations as key stakeholders in the One Health response to AMR at global, regional, national, and local level. Since 2019, when this report then was published, we came a long way, as was shown before, and there has been some results and achievement, like the multi-stakeholder partnership platform, the people-centered approach to address AMR in human health, as well as more public hearing for civil societies. But at the same time, as was also mentioned by John, there are several gaps that still need to be filled, such as ensuring civil society participation in high-level pre-meeting, and at the meeting itself as an important part of the successful mobilization. Next slide, please. Here, I also want to show, and I guess this is my last slide, an initiative that we launched on the 26th of September, which is called, as you can read here, Impactful Approaches for Community-Wide Engagement on Antibiotic Resistance. You have a QR code where you can find the recording of webinar 1 and webinar 2, where also some members of UICC participated. The first webinar was on bringing together different type of approaches on community engagement from different contexts, different countries. Webinar 2, yeah, sure, you can also go ahead and do all the different clicks. Sorry about that. Webinar 2 instead was more technical on impact and evaluation. So how does success look like? How can we measure community engagement initiatives? When is that important to start thinking about it? And next week, on the 29th of November, we're going to have a hybrid workshop bringing together experts from all over the world discussing both the outcomes of the two webinars, but we're going to deep dive into more challenges and have a workshop on solutions. And the outcome of this initiative will be a report, policy brief that I'm hoping to share with you very soon. And here you see some of the highlights, but I really encourage you to go to the website and check the recording yourself. Some of the highlights here is the need for a clear narrative, for example, distinguishing between what is community engagement, community-led type of initiatives. Another important point that was mentioned by one of the panelists was that if you cannot measure it, it never happened. And this is, I think it's very important because this makes us realize that we need to think about metrics for evaluation of the impact that we can also communicate to policymakers. Making the investment case, also extremely important, having more funding to do the important job that communities are doing and also organizations working with communities and civil societies. Not least, engaging the cancer community for addressing AMR for better cancer care. And last but not least, trust the patient and trust the communities. This was also mentioned by one of the panelists. Extremely important also to take into account the needs of the patients and the needs of the community. That's the central part, or should be. Next slide, please. Yeah, I just want to thank you, and you can reach me out at all the links that you find in the many QR codes that I put around my presentation. Thank you.
Thank you so much, Andrea, for reinforcing the point that AMR is not just about overuse and misuse, but also about lack of access. And thank you also for stressing the need to ensure that the communities are engaged and civil society groups are engaged as key stakeholders in the global response to AMR. Thank you so much. I think I can open the floor to questions. And Yannick, maybe we can remove the slides. Stop sharing the slides, sorry. The floor is open to questions. We can take it off, actually. Okay, so then while we're waiting for others to post their questions, I might start Diane off with a question, if that's okay. So Diane, in the past, there have been questions on how cancer patients enter hospitals multiple times. So basically, both as inpatients and outpatients, and they just keep entering multiple times. And are therefore more likely to be exposed to infections. Does this come out in the data that you talked about?
Yeah, thank you, Shalini, for the question. And for sure, I think that the data shows that cancer patients and their interaction with healthcare systems, to include the medications that they're being given, are putting them in a higher risk for getting a drug-resistant infection. And I think one interesting part of the data that I didn't share today, but we have been analyzing, is one of the recommendations to reduce those risks is to move patients out of hospitals to ambulatory settings, so they're not as exposed to the healthcare systems directly. Yet what we're seeing in the outpatient data is that patients undergoing chemotherapy, the cancer cohort, actually still has significantly higher rates of drug resistance in their isolates versus other outpatient non-cancer patients. So even though the move to keeping patients safer by leaving the hospital systems is important, we also need, from an AMR perspective, be aware that these patients, whether they're interacting with the healthcare systems at different times and their microbiome shifts, their medications put them at a higher risk for getting these infections, all those complicating factors actually carry into the outpatient setting as well.
Okay, thank you. Thank you, Diane. I'm going to direct my next question to Scott. So Scott, you talk about leveraging information systems that combine data from cancer registries and microbiology databases. So is integration of information systems really that important? And what if someone has several non-integrated systems, each of which is actually working well? How do you deal with that?
I love this question because one thing I learned years ago doing IT work is to never solve a problem that people don't realize they have, because it means that it's a 100% chance of a failed implementation. So if somebody has 25 systems and 25 groups of personnel and everything's happy, this might represent some of the countries here where the resources is adequate. I never run across places like this. So usually there's 25 systems, but almost all of them are not working well. So I would say for low and middle income countries, integration is obligatory. It's just cruel torture. The number of demands put on busy healthcare workers and busy administrative workers and busy lab workers to try to keep up with everything. They just cannot. It's absolutely impossible without integration. So I would say, and which Diane, I was wondering as you were talking, how did you get Beckley Dickinson interested in this? I always think of you guys as flow cytometry people, but obviously I'm missing a big piece of it.
Yeah. So BD is a medical device company, and we span infection prevention, antibiotic stewardship, medical management, so very broad diagnostics. Including the flow cytometry. So we have a data set here in the US that we have access to, that we're able to analyze that data.
And the humanitarian efforts are right there parallel to the commercial efforts.
Oh, absolutely. Yeah.
Adjacent.
I mean, it's critical that we inform our global health world of the impacts that we're able to analyze, so that we can have better advocacy at the global and regional level.
Yeah. Thank you, Scott, and thank you, Diane. I'm going to. Sorry, Scott.
No, I'm just dreaming if every company had a Diane's team working next to it, we could really make some tremendous progress. It's really a really great model.
Agree. Yes. So I'm going to direct my next question to Alex. So Alex, given the limited resources and competing global health priorities, especially now with COVID-19, how do we make the case that antibiotic R&D really needs a focus and push in investment?
Sure. Thanks for that question. I mean, I would say that, part of making the case comes back to making the case for AMR overall. And there has been a lot of progress on that, especially with the publication of the Graham study. I think that was a real landmark moment because we were able to put numbers to the global burden of AMR. And that was a really significant, missing piece up until that point, I would say. But other things that are underway are, pieces of work to estimate the economic case, to make the economic case for AMR, to estimate the cost of inaction. I think all of those things are really critically important. But insofar as R&D is concerned, I think that, there's a few elements that we can leverage. I mean, now that there has been so much investment in CARB-X, GARD-P, the AMR Action Fund, and others, we're starting to see some successes of those interventions. We're starting to see products reach the market. We're starting to see access partnerships being formed. So, for example, with the GARD-P and Shionogi product cefiderocol, there's now a licensing agreement with Orchid, an Indian company, to actually make that product and distribute it in LMICs. So, just showing that there's a model that works, I think, is a very compelling argument to then continue the investments and also enhance the investments. One of the things that I think we're missing in R&D probably is targets. So we always say that the pipeline is insufficient, and we know inherently that it is, but I think it would be a lot easier to make the case if we had a set of agreed common targets that said we need X, of a specific type of antibiotic in the next 5 or 10 years. That would really go a long way. There are some estimates of that. CARB-X has their estimate of 6 new antibiotics per decade, for example. But something that the whole community could get behind and agree to and commit to would be really important. And I think it could also help to galvanize further commitments. Oh, and maybe one last thing, because you mentioned COVID as well. I think, of course, just making the links and reinforcing at every opportunity that AMR is its own pandemic and is also an exacerbator of other pandemics is really important as well. We know it's a disrupting factor in the management of emergencies. And we know in turn that during emergencies, we see a sharp spike in antibiotic use, but also misuse. And so just making those linkages and doing what we can to get AMR considered as part of pandemic preparedness in the pandemic accord, I think that's also, critically important.
Thank you, Alex. Thank you for that. I'm going to address my next question to John, and then I'll have a look at the chat room to see if there are any questions. So John, this question is for you. Why do you think we are just not getting there? We're just not there yet regarding the global AMR crisis, in spite of absolutely everyone agreeing that something needs to be done urgently. There's been numerous action plans, strategies, agreements, and also high-level interest. And still, we can't see the necessary measures and political will from the global community. And why do you think that is?
Yeah, first I would say that I agree with Alex that you have to continue doing investments, and that's AMR is all over. And the world saw some improvement after the high-level meeting in 2016, but many gains were then lost during, as you said, during the COVID. So I think that requirement for AMR is have a new political priority, and we have to build the case because the problem is complex. It's combined with animal welfare, agriculture, development. So many ministers have to come on board, not just health. And the problem is also that AMR doesn't have its own patient group to advocate, because it's even though this is important for all groups, people with chronic diseases. So we have to build this patient's voice. I think it's very important. And as Andre said, we must remember that the problem isn't just about over and misuse. So we have to have access to all. And then it comes to this, we need new models for new financing models, just push and pull mechanism. So in Norway now, we will have a new action plan on AMR next year, and it will also have an international chapter, because we see this problem is not national issues, it's international. So I think we have to need to build broader political commitments from all sectors, civil sector, the governments, and many different ministers. So yeah, that's my answer. Thank you.
John, do you or does anybody here have a model, like if one country just goes off the plot and massively abuses antibiotics, how long does it take for that to affect the entire world? Does anybody model that?
we haven't modeled it stuff. But that's
Because
a
I love
good,
your idea, like
yeah,
reach out.
we will dig
Anybody?
into it.
Alex,
Thank you.
have your people been
Action
listening?
item.
Action item.
There's actually a question in the chat from Lisa. The Economist had a story a few weeks back about using AI to discover new antibiotics. Is this an area of research being pursued? Perhaps I'll direct this to Alex, if that's okay. And if anyone else would like to contribute as well, please do. But Alex, it's over to you.
Yes, so I mean, there have been a few articles. I think it's still, relatively early days with the application of AI and machine learning to antibacterials, but certainly we're following it very closely. We hope that the potential of that can be harnessed to the maximum that potential, because we need all of the technology that we can get, essentially, especially because we're looking for novel molecules without cross resistance. And so anything that can help, screen large volumes of compounds and those types of techniques, I think, are really exciting. And yeah, we're following it closely. And in our next edition of our pipeline review that we did this year, which isn't quite published yet, we have a section on AI and the potential of AI. But yeah, we would really like to see that leveraged to the maximum full potential.
Thank you, Alex. I'm going to address my next question to Andrea. So Andrea, you talked about the importance of community engagement to address AMR. What do you consider success to look like in the community engagement approach that you have presented? Because as you mentioned, if you can't measure it, it didn't happen. So yes, it's over to you.
Thanks, Shalini. And this is an excellent question that we also, asked our panelists during our webinar. And there is not a clear or a single answer, I would say here. I think success has different shapes and forms. And also for us being now present in our southern nodes, it's really important to take into account different factors that maybe in high-income country we usually don't take into account. Something like extremely important that we see here is, for example, the need of addressing corruption to begin with. And another important thing, as perhaps was mentioned by some others, access to drinkable waters and healthy food is also important. And then last but not least, this is extremely important that we make sure to engage communities and that we listen to what communities need and what are their asks. And there has been several approaches over the years which have been more on a top-down type of level, but we also need a bottom-up type of approach. And we from React are trying to provide that platform where those different voices can meet and can speak the same language. And I think whenever we're going to reach that goal, then we might say we have some type of success and we can move forward. But also something that was mentioned by others, I think the high-level meeting next year, it's an extremely important milestone and hoping to reflect some of the messages that the communities are trying to portray and trying to be advocating for. So that would be also another milestone that we're really looking forward to. So this is my answer.
Thank you so much, Andrea. I'm just going to have a look at the chat. Yeah, I see Philip has posted a question. I'm just going to read it out and then perhaps I'll direct it to, I'm thinking Alex, but maybe Diane and Scott, whoever would like to contribute. So developing a new antibiotic can take 10 to 15 years and cost more than $1 billion is a statement which always finds its way into pieces on antibiotic R&D. How reasonable is this figure of 1 billion? Do we need to debunk it? For example, Archigen raised less than 200 million during its entire lifetime before it went bankrupt, and it successfully brought a new antibiotic into the market. So is this a realistic figure? So Alex, perhaps if you could start us off on this, and then maybe Scott, John, I'll let you decide. Alex.
Yeah, no, thanks, Philip, for that that somewhat challenging question. I think, the reality is whether the number is purely accurate or not, it's very expensive. It does cost a lot. It depends on if you're talking about the full, from discovery down to market access value chain, or if you're just talking about clinical development. It depends on, where the company is located, the size, and so on. So of course, there's a lot of variability there, but the reality is that it does cost a lot, and it costs a lot more than what the market can return to those investors when those products become available, because the large majority of the new products becoming available are last resort reserve products. I would hypothesize as well that the purely innovative products may also cost more to develop than some of the Me Too products again. So there's different things like that. I know that the TB trials take a lot longer, the clinical trials, which then adds to the cost. So yeah, you could probably debate the intricacies of the costing a little bit, but the reality is that it is really costly. Now we have most of the large multinationals, have exited the antibiotic R&D space, and over 80% of what's being developed today is being developed by small and medium enterprises, SMEs. So it's even harder for them to make their way through the pipeline, and that's why push funding is so important to support those efforts, also by academics, not only by SMEs. And so that's kind of part of the story, and then the other part is making sure that, because of course you mentioned that they went bankrupt, that when products actually enter the market, that there's a viable system and market to receive them and to make them available and used appropriately through some type of system, pull incentives, but also other types of mechanisms that can ensure rapid uptake and access. I think that one of the other areas that is a real difficulty for some of the suppliers are the costs and complexity of country by country product registration, and how much that adds to the timeline. It adds to the costs, it adds to the disincentives. And of course, I'm not suggesting we don't need stringent regulatory control. We absolutely do, but doing it in such a way that enables products to start becoming available in an efficient way, and some type of reliance mechanisms as well, where you don't have to go country by country necessarily each time. Those are some of the types of solutions that could also make things more efficient. So I think it's not only about upstream investments, it's about also improving some of the other non-financial elements that help to ensure a viable market for suppliers, and also then access at the end of the day.
Thank you, Alex. Would anyone else like to add to that?
Well, Philip, actually, do you know of any debunks for this, or any data showing that this is a little bit inflated?
No, nothing as such. Nothing as such.
Okay.
So I'll perhaps look at the chat box and take one last question. I think there was one from Tim, if I can find it. Oh dear, I can't find it.
Resilience.
Got it. Yes, thank you. So resilience seems a new overarching concern for many areas, and there have been several meetings on this at the London Global Cancer Week. How do the panelists think this can be mobilized for AMR? And the concerns of 2023 are different to those of the HLM in 2017, of course. So who can I give this one to? Oh, Andrea has left us, unfortunately. Scott, would you like to start us off on this one? And then perhaps I'll ask you to jump in, John.
Yeah, John, please. For me, resilience is like, you don't want just one antibiotic that's going to work for that patient. You want 5 by different suppliers from different manufacturers, ideally with different distributors, and some on a boat and some by plane and some locally on your continent. So There were shortages of mercaptopurine. This is a pennies per pill drug, absolutely critical for childhood leukemia. And it was 1953 is when it was approved. So 70 years later, there were shortages in UAE, like rich countries couldn't get their hands on it during the pandemic. So you think people relapsing with their cancer, and of course, when they relapse, they get salvage therapy. When they get salvage therapy, they get all kinds of infections, including resistant infections. So curing people in frontline non-toxic therapy is another way to prevent death from AMR, because they're not as myelosuppressed and immunosuppressed. So for me, resilience, if anything proved with the need for it, we just experienced it the past 5 years.
Thank you, Scott. Would anyone else like to add something to this question? It's the last question. Diane, John, Andrea?
Yeah, maybe I'll make one comment, and I think it really reflects the discussions we've had today in bringing the AMR and cancer communities together to have these discussions. I think it's so critical, and it will add a higher dialogue and impact, I believe. So when I think of resilience, I think of it more from an advocacy perspective, and how can we keep this dialogue at a very high level, making sure that at the high level meeting next year, that we actually have clear targets identified at a country level, at higher levels as well, to make sure that we're actually creating action. So I think the one comment that we've seen is, yes, the first meeting did a great job in identifying the AMR as an issue. However, we have not yet quite resolved it, or even put a dent in it, some may say. So we have great opportunity to make a difference, and working together and bringing different groups to have these very important discussions together will be a critical element to make a change.
Andrea, please go ahead. Thank you, Diane.
Yeah, sorry, I had to disconnect for a second, but I'm trying to pick up what was the discussion about. But yeah, I totally agree with what Diana said. And also, some of the asks might be different, but I think some of the asks from 2016 are still the same. And we need to still fulfill many of these. And one of those, as I mentioned in my presentation, is indeed coming together. And I think this meeting today and the work that UICC is doing with the task force, it's an excellent way of bringing together different type of actors. And I also want to mention that from the React side, we're going to provide what are our asks for the high-level meeting. And I'm happy to share those when they're ready with the group. And you can check them and see whether that resonate also with your mandate and what you think of what we discussed today. Thank you.
Okay. Thank you. Okay, well, so this brings us to the end of this session, and basically big message. AMR needs to be addressed. It's affecting everyone across all therapeutic areas, but unfortunately, it disproportionately affects the cancer community. And if we don't address AMR, well, cancer care will just go back decades. It'll just be completely undermined. So with that, I'd like to thank the panelists and our audience for this very insightful discussion and your time. And I wish you a nice rest of the day. Sorry, Andrea, did you want to say something?